Um, yeah, thank you, Sheila. Thank you for having me. This is the second time I've presented at this symposium. I did it about 2 years ago, 2 or 3 years ago, and really enjoyed it. I'm 6 years into practice, and I just love my job. And I've been around these conferences enough. I'm starting to recognize people and get really used to the system. So thank you for having me. I work at Nebraska Spine and Pain Center in Omaha. And it's a great group of people to work with. You probably all know Sheila Friedmeier and Linda Wilson. Sheila was just up here, of course, and they do a great job connecting the doctors to all the other parties in this room. So we are happy to take care of your patients. So they asked, the question was what I wanted to present on. And I think one thing that is mysterious to me beginning my spine surgery training and in my early years of practice is, who needs a spinal fusion? I don't ever really remember being taught that. There wasn't a lecture about it. I would join my professor in the operating room and he would just tell me this patient needs a fusion, which just means to most of us they need rods and screws. Why do some patients need that and other patients don't? Rods and screws scare some people compared to surgeries without rods and screws. So this is an original presentation. I thought of it when they asked me what I wanted to present on, and I'm excited. There's a lot of original thought here, and I hope it makes sense. So I plan to talk for about 30 to 40 minutes, and there'll be time for questions at the end. So I don't have any disclosures. I have no financial relationships outside of my personal surgical practice. I'm not compromised. I don't work for anyone besides me and the patient. So send them my way. So lumbar spine surgery. So I'm gonna, of course there's the cervical spine, thoracic spine, and lumbar spine. Today, just to keep it simple, I'm gonna focus on the lower back, which is the lumbar spine. And when I think about spine surgery options for people with surgical spine disease, this is way oversimplified, but I think of it in two ways. First, there are surgeries that are, quote, decompression alone, unquote. So these are patients that, in the words of my patients, they don't need rods and screws. Okay, these are the smaller surgeries that we think of. And this is where spine surgery, what it boils down to in a lot of ways is you're removing something that shouldn't be there. You're removing pathology that is pushing on a nerve, is one way to think about it, okay? So decompression alone is where you're just removing stuff. You're not compromising the spine integrity, the structure of the spine. So you're just making a hole in the spine and taking something out and everything's great. And examples of this are what everyone calls a microdiscectomy, which is where you just clip out part of the disc in the canal. Most of us have heard of that. And then there's the classic, probably the oldest spine surgery is called a laminectomy. And then you can like cut out arthritic cysts and things like that. So these are what I think of as the small surgeries, the microsurgeries, where they only take an hour and patients go home the same day. So some patients have pathology that's amenable to a smaller surgery. And then the other type of surgery out there is what I call decompression and fusion. It has all the great characteristics of a decompression surgery, plus rods and screws, okay, which is stabilizing the spinal segment. The spine moves. A fusion stops it from moving. So examples of this. There's a whole bunch of different fusion techniques, and that's probably confusing to someone that's not in orthopedics or spine surgery. I think even an orthopedic resident would be confused by all the terminology. Transforaminal lumbar interbody fusion, it's called a TLIF. There's a classic posterolateral fusion. There's an anterior lumbar interbody fusion, ALIF. There's a lateral lumbar interbody fusion, XLIF or LLIFs. There's all the lifts. Don't let the lift scare you or make you nervous. It's just different ways of accomplishing the same goal, and that is to decompress the spine and to stabilize those segments. So the main thing, a fusion is a stabilizing surgery. More on that here. First thing you got to understand, what is a spinal segment? It's better called a spinal motion segment. The spine is a stack of joints, complex joints. There's a lot of parts. I like to tell my patients hip disease is easy to treat because there's only one hip joint, the ball and socket. Once you cut it out and replace it, there's nothing else to hurt in that area. The spine is so complex, there's so many parts. And there's so many parts, I'm not even going to talk about them all right now, but what I have in blue here, a spinal motion segment, two bones, they're called vertebrae, are connected, but they move. So that's what's called a joint, okay? Building upon that, you have, right? You got a vertebrae here, and you got a vertebrae here. Okay, we're looking at the front of it. We're looking at the side of it, okay, which is the picture on the left is going to be the side of the spine. And then here is the back of the spine. So you're looking at someone's back here. The back of the spine is what's pictured on the right side. So you got the side of the spine on the left, the back of the spine on the right. The bones are connected by 3 points, and these are called joints. The one in the front, the big one that everyone knows about, that's the intervertebral disc. Okay, everyone's heard of a disc herniation. It's big, it's on the front, everyone knows about it. So that's one joint. The other joints, there's 2 joints on the back here. They're small. One is on the left, one is on the right, and there's a set of them going up the spine. These are called facet joints. And there's cartilage between them. There's 2, and they're small, and they're on the back. So there's 3 attachment points connecting the vertebrae together. Okay, that's the basic thing you need to understand for today's presentation. There's 3 attachment points between 2 bones. When I'm explaining this to a patient in the office, I've used the analogy, a spinal level is like a 3-legged stool. The 3 legs are the joints, the disc and the 2 facet joints in the back. If one of those legs, if one of those joints is compromised, the stool falls over. So that has to do with spinal stability. Spinal stability is what you need to understand when you think about who needs a spinal fusion. An unstable spine needs a fusion. So basically, if one of these 3 joints is removed, the spine needs to be stabilized with rods and screws. And there's a bunch of reasons why that happens. Here is the new twist for you guys. First time I've ever given this presentation or seen this described this way is my new analogy. A spinal segment is a floor of a skyscraper that is supported by 3 pillars. This is what I mean. On the left is a spinal column. What I have in red there is one floor or one segment or one level. All those words can be used interchangeably in this presentation. And there's 3 legs or 3 pillars, okay? And I have it circled, the joint and the disc and the 2 joints in the back. Over here I have this picture. Everyone knows these support pillars in your house. I just remodeled my basement. You wish that pillar wasn't there. How do you hide it? How do you remove it? It's in the way of something. That's where I wanted to put the couch. You can't remove it because it's structural. The roof is going to collapse, okay? So that's how I think about these joints. You cannot remove them or else that floor of the skyscraper is going to be compromised and it's going to fall apart. So here's just some illustrations. Again, one of my patients drew that for me, that picture in the middle, and just gave it to me a few weeks ago. It was just, I don't know, sometimes you feel like God's helping you with the presentation or something, because that is just perfect. That is a spine skyscraper reaching to the sky. All right, so let's look at lumbar fusion just as a definition. It's kind of funny, as I was preparing for this presentation, I grabbed one of the books, one of the spine surgery books for spine providers that you read when you're getting ready to take the boards or something like that. And I was looking for the definition of a fusion. It's nowhere in the book, okay? No one ever explained to me what a fusion was. Okay, the Oxford we all know what a fusion is. It's taking 2 things and combining them together. So the process, this is the Oxford English Dictionary, the process of joining 2 or more things together to form a single entity. Okay, so let's put that in spine surgery language. It's joining 2 separate bones, vertebrae, together to form a single bone. So instead of 2 bones, we have 1 bone. All right, and now here's my anthropomorphic simplification that I give to patients. A spinal fusion is tricking two separate bones, so two vertebrae, into thinking they are fractured, so they heal together to one bone. And I often use the example of a fracture when I'm talking about fusions. If you fracture your forearm and it heals together, you are fusing two separate bones together. So this is like the spine is fractured. That's when I'm creating that biological environment, and it comes together. Okay, and that's a key thing. A spinal fusion is a biological process that takes time to heal. Screws and rods do not fuse a spine. Screws and rods are an internal cast. Screws and rods are like putting a cast on your arm for a broken forearm. Just because you stabilize it doesn't mean the bones have healed together. Just because you put that cast on your forearm, you still have a broken forearm. It's a biological process that takes 2, 3, 4 months to happen. So the screws and rods are an internal cast that hold the spine stable while it heals together. The spine is not fused until the bones heal together, which takes months. I tell the patients, I don't know why I say this, it's such a bad idea, but I tell the patients, the screws and rods go in, the bones heal together over 4 months. Once the bones heal together, you don't need the screws and rods anymore. You can take them out. They're not doing anything. The bones have healed together. The bone is stronger than the screws and rods are. Okay? I don't know, that's stupid to say that because I never take them out. I will never take them out unless I have to, but you could. Okay. So I got this image from AI. This is from Grok, Elon Musk. I said, draw a picture of an orthopedic spine surgeon as a chef, and this is what it spit out. And I thought it was pretty good. So what's the recipe for a successful spinal fusion? The first thing, this is what you think about before you do the surgery, is patient biology. Or we like to use the word protoplasm, the makeup of the patient. They need to have strong bones, so not osteoporotic. Osteoporotic patients don't do as well with spinal fusions, okay? And then they need to have good blood supply, which means no smoking. We all know, all spine surgeons know that tobacco use and smoking increases the risk of surgical failure, which means non-union, the bones don't heal together. So it's a joke in my clinic. I say, stop smoking, exclamation point, and then I soften it with a smiley face. Because patients, I'm not being mean. I have nothing against smokers. I know smokers. I think it's dumb, but I have nothing against you personally. If you guys want to meet smokers, you come to a spine surgery office. You won't believe how many people still smoke. It's crazy, but it's not personal. And I joke with patients. I'm like, I don't care if you start smoking 6 months after your fusion heals. You got to stop smoking, because if your fusion does not heal, it's a waste of time. And I'll get into that later. So stop smoking. Then the other thing, now we're talking surgery. What do you need for a spinal fusion? You need clean bone. Bone ends heal together. So if you have soft tissue, let's say ligament or disc or muscle or something between two bones, the bone just doesn't grow through it. The bone needs a clear path to connect to each other. So part of the surgery is cleaning all the soft tissue off of the bone so they have the potential to heal together. And then once you clean off the bone, you roughen it up. You kind of take off, you make it start bleeding. And this is why I use that analogy, or that saying, you trick the bone into thinking it's fractured. So when I go in there, I take a drill and I roughen that bone up so it starts bleeding, and it thinks it needs to heal to something. Okay? And then the last point here, which is really a topic for another lecture, is maximizing bone surface area for healing. And this is, you've all heard of the cage, right? That's one of my questions when I'm telling someone about a spinal fusion. Do I need the cage to replace the disc? And everyone has all these different perceptions of what cages are. Some are good, most of them are bad. Some are good though. Why do you need a cage? The cage goes where the disc was, right? And that cage is filled with bone, and it creates a channel between the end plate above the disc and the end plate below the disc. So the disc here gets replaced with that cage. That's more surface area for bone healing. So it's a greater opportunity for a successful and strong fusion. That's why we do all the T-lift, A-lift, X-lift, all those things, is to maximize bone surface for healing. What's the next ingredient? Is You need to stimulate healing with what's called bone graft. This is another lecture, but there's 3 properties of bone graft. It needs to be osteoconductive, which means a scaffold. So there's a matrix for bone to grow over, and for this we typically use cadaver bone, which is dead sterilized bone, but it's the same matrix of bone, so bone likes to grow onto it. So that's number 1. Number 2, osteoinductive material. These are growth factors, proteins in our body, which are now made in laboratories that stimulate bone growth. Like the most famous one is called BMP, or bone morphogenic protein. It's famous because it works and it's very expensive. And then the final thing is you need osteogenic, which means cells. You need patient biology. There's certain cells in our body that produce bone, and they're called osteoblasts. So those are the 3 things you need to stimulate that fusion to heal. And of course, we use everything we can to get it to heal. What else? What's the next ingredient in a spinal fusion healing is immobilization. This is where the rods and screws come in. This is the internal cast, because fractures heal when motion is minimized. So if you read one of the frustrating things about spine surgery is some of the research and some of the educational materials are so old. If you open up a textbook and you look at spinal fusion, they'll talk about doing a fusion without rods and screws. And that has been proven to be less effective than rods and screws for 30 years, but people still talk about it. The truth is, rods and screws stabilize the spine like a cast so it heals together. It's the standard of care. And then, of course, post-operative activity restrictions and bracing. So I also joke with patients, patients get so confused about orthopedic surgery in general because there's different protocols. If you have a knee replacement, you do physical therapy right away every day for a month. You're getting that joint moving. They come in and they try to maximize range of motion. Spine is on the different end. Spine fusion is fracture healing. I joke, if I could put you in a cast and put you in a lazy boy for 3 months, I would do it. So we protect our patients. We don't let them lift heavy loads or repetitively strain their spine. And then, of course, I've alluded to this, the spine needs time to heal. All right, I got to get going. All right, the spine is a skyscraper. This is the new analogy. This is the basis for the lecture today. So when do you need a spinal fusion? And I'm going to continue on the skyscraper analogy. The skyscraper analogy, a word of caution. If you talk about this to any other spine surgeon, they're going to have no idea what you're talking about. But I think it's a very useful way to think about this. And I might turn this into a book. So when do you need a spinal fusion? We talked about the 3 pillars holding up the floor, the level of the skyscraper. Well, obviously you need it if a pillar is broken. Another reason, if a pillar has decayed or it's no longer working, the skyscraper is falling over. If the pillar, so one of these joints, if it's blocking access to something that needs to come out, if the ceiling is sinking, or if the floor of the skyscraper that's bad is next to a previously fused floor of the skyscraper. So you need to extend it. All right, let's take one of those at a time. I've got time. All right, so first thing, a pillar is broken. Spine translation. So getting away from the analogy I made up to stuff people actually talk about, the spine is fractured. You have an unstable fracture. And here's a couple x-rays. So this is called a burst fracture. Over here I've got arrows. So the vertebral body up front is fractured, and then the joints on the back are fractured. And you can see that best on the CT scan. Here's the vertebral body fracture at L3. And then over here, look, those little joints in the back are also fractured. So on this patient, at least 2 pillars have been injured. This is someone who needs a spinal fusion, okay? And I was putting this together this last week. And this is a patient I saw recently, and he needs a spinal fusion. I was all ready to do the spinal fusion because of this analogy. It's unstable. Going back, patient biology is a problem for this guy, okay? He's not ready to have surgery. I put him in a brace, but my prediction is he's gonna need a fusion. We'll see how it goes. Okay, note this though, not all spine fractures are unstable. So just because your grandma tells you she broke her back, you don't need to say, well, you need a spine fusion. In fact, most spinal fractures are not unstable. And this is what, for example, a compression fracture, which is what I have depicted here. Okay? The reason why these are not unstable, a compression fracture, I would argue the injury is not to a pillar. It's to the bone between the discs. The disc has not been compromised. The joints have not been compromised. So the pillars are intact. This can be treated in a brace. All right. The next reason why you might need a spinal fusion. Moving on from fractures. A pillar has decayed and is no longer working. So one of the three joints is not working, at least one. And there's a couple different examples of this. Spine translation number 1, degenerative spondylolisthesis, which is Greek for slip disc. Everyone calls it a slip disc, which is fine because spondylolisthesis means slip disc in Greek. But this is one of the more common age-related spine conditions that I see. And up here, this is an older patient here where L4 and L5, you can see L4 is not perfectly stacked on top of L5. L4 has moved forward. That's what we call a slip disc. There's unstable. It's unstable. It's malaligned. And usually in this situation, patients have nerve compression on MRI, and that's their presenting symptom. They have neurogenic pain to their legs associated with back pain. And that's because it's unstable. Over time, that degenerative disease has made the facet joints on the back wear out to the point where the spine is moving on itself abnormally. Okay? And spine is such a big topic. I don't want people to go home with the wrong message. This is not always a surgical problem. We do physical therapy, we do injection, we do medications. This is really common. Not everyone needs surgery. It depends upon how much pain they're having. Okay? So if they're having pain and nothing is working, then I take the pressure off the nerves and I stabilize it. All right, another example of a pillar decaying or being destroyed is when a tumor gets in there and destroys it. So here's a young woman with metastatic breast cancer I took care of. She comes in, she can't walk hardly. She's starting to do the furniture surfing. Okay, well, she has a bone, her breast cancer has infiltrated L2. And here it is on the MRI. The disc above and below are completely gone. There's no structure here at all. It's been completely destroyed. And it's actually gone to the back of the spine too. This is unstable. The structure it's just destroyed. It needs to be replaced. So for this patient, I cut out the vertebral body, replaced it with that big spacer, and spanned it a couple levels above and below. So tumor destruction. And then whenever you talk about tumor, you also have to think about infection. So infection, like a tumor, they act a lot like each other. Infection can destroy the bone in the same way. And here's an example of a patient I consulted with an infection. Sometimes these patients are so sick, the surgery is too big. All right, next reason why you might need a spinal fusion. The skyscraper is falling over. Spine translation. Scoliosis or kyphosis. Kyphosis, everyone kind of knows scoliosis is what I have up here in the picture. Kyphosis is when you're stuck leaning forward, and I've got that on the next slide. Okay? But this is a pediatric patient. I take care of all spine disease and pretty much all age patients. I mean, teenagers, young teenagers, pre-teenagers and above, I'll take care of. So this is a patient that has scoliosis, and they did the bracing. The bracing kind of held it, but now it's getting into the surgical range. The reason why we fix this is the skyscraper's falling over, and we think it's going to continue to fall over as they continue to age. As they become an adult, it's just going to become worse. So a mild scoliosis usually doesn't need surgery. Once it reaches a certain severity, we do surgery. And this is one I did a couple years ago and straightened out. Here's that example of kyphosis. This poor lady, she had a spinal fusion done 20 years ago, and then she just kind of fell off the face of the earth a little bit. Like she never saw another spine doctor until she came and saw me a couple years ago. And she literally is walking like this. She cannot straighten up. And she's not even 70 years old. Like, she's got a lot of life left to live. It was a horrible situation. And she's stuck like this. She cannot straighten up. The reason for that is, for some reason, For some reason, I look back, I know the surgeon who did the original surgery because he's my dad. And the post-operative x-rays look great, they look good. But for some reason, the top two levels here went to crap gradually over time, and then they started fusing together. So she's bent forward, fused together, so she cannot straighten up. So this is a gratifying case. So I did this complex surgery called a pedicle subtraction osteotomy. There's not a lot of surgeons that do this, at least not in this region. But what I did was I cut the spine in half. So it's fused together. Those bones don't move, and the only way to make them move is to cut the spine in half, and then what you do is you pull the patient back on the operating table and you fuse them up. And I'm very proud. All right. The next thing, and this is where we start going to higher level spine surgeon thinking. And when you need a spinal fusion, this is a good one. And this is one that I'm constantly explaining to insurance companies who say the patient doesn't need a spinal fusion. The insurance people, they don't get it, okay? A pillar is blocking access to a structure that needs to be removed. I got a couple funny pictures. Okay, here's a pool table in your basement. I just found this picture randomly. I don't even know who to credit it to. But look, there's a structural pillar around it. You can't get that thing out of there unless you remove the pillar, or let's pretend that's the case. My dad, who's a spine surgeon, he goes, Chase, well, you can just cut the pool table in half and, okay, thanks, Dad. Let's just pretend you cannot cut the pool table in half. You have to remove the pillar. Well, it doesn't matter if the pillar was broken in a car accident or if I broke the pillar in surgery. If that pillar is removed, the spine is unstable. So I've created instability by removing the pillar. Here's another example. Here's an MRI machine that's getting moved into a room. Our practice has experience with this. We just got a new MRI machine a year ago or so. They don't fit through standard doors. You got to cut a hole in the wall, okay? And when you cut a hole in the wall, that's a structural problem. That's an issue. So I think the best example of this, this is a work comp patient I took care of a year ago or so. But this patient has a disc herniation, but you can't see it. It's not in the center of the spine. This is the spinal canal, right? I don't see a disc herniation there. But if you scroll over to the left side, it's on the side of the spine. The patient has severe left leg pain. There it is. Here's a top-down view. There's the disc herniation. Most disc herniations, 90% of them are in the middle. This one, 10% of them are on the side. The problem with this is, what's in the way? The facet joint's in the way. I can't get that disc herniation out unless I remove the facet joint on the back. So on the model here, you guys can't see this, I know. But this model actually shows a foraminal disc herniation. So I'm talking about on the side of the spine down here. It's behind this joint. The only way I can get there is removing that joint so I can see it. It's like the pool table stuck behind the pillar. The only way I can get that pool table or disc out of there is removing the pole. And that's what this patient got. He did great. He was a goofy guy. He's a work comp guy. Just kidding. All right. The other thing is, the other reason why you need a spinal fusion is the ceiling is sinking. So that level, the ceiling is coming down. And thank you, Getty Images. This came in really useful. I love this picture. I love this picture because the main thing I wanted a tall guy with a low ceiling, just to illustrate a low ceiling. But this picture is perfect because it also shows the window. This is where the nerve is coming out. The nerve comes out the side of the spine through this window. So if the ceiling is sinking and the window is sinking, the window where that nerve comes out, that's becoming tighter. That's called foraminal stenosis, okay? You guys don't have to, just enjoy. You don't have to remember any of this. So this is a picture from the Cleveland Clinic that's showing foraminal stenosis, okay? The top picture is normal. We got a disc, a nerve comes out the window behind it. Notice that disc is healthy looking. It's the proper height. Now look at the disc below. The disc is narrowed And that window, it's all part of the same structure. It's all part of the same level. If the disc ceiling sinks, if this becomes narrower, the window where the nerve comes out becomes narrower and it gets pinched. So here's an example, okay? This is a young woman who has, you can clearly see, isolated L5S1 degenerative disc disease. This is narrowed. Compare it to the level above, it's dramatic. There's some patients that are young that just have bad spine disease at the bottom, and they start getting nerve pain down their leg because the window here, where the nerve comes out, has narrowed with the disc. So this is a great example of what's called an anterior lumbar interbody fusion. I went from the front of the spine and put this spacer in there. Okay, I didn't see the nerve at all during surgery. I didn't see it, even though that's what I was treating. All I saw was the disc space, and I jacked it up with this spacer, and that increases the room for the nerve in the back. Her leg pain went away. So this is another way of using a spinal fusion to correct some of these issues. Okay, and then I think I'm doing great on time. So continuing the skyscraper analogy, the last reason I'll mention for a spinal fusion is the level or floor is next to a previously fused level floor. My spine translation is disease adjacent to a fusion requires a fusion as a general rule. I recommend it. I've tried it other ways, it doesn't work. And I'm not the first to try it. So here's an example of a patient that had a prior L4-5 fusion. They're having pain. It's from this level above, and you can see it on the MRI. This is the prior fusion level. You can see where the bone has been removed from the back. The nerve sac is wide open. Now they've become stenotic or narrowed above. The best way to treat that is extending the fusion one more level up, okay? All right, so I'm getting here kind of towards the end a little bit. I got a couple more slides. So the spine as a skyscraper. A spinal segment is the floor of a skyscraper supported by 3 pillars. So what are some other things to mention about a fusion? A fusion is complete treatment of a spinal segment. Complete treatment. You're removing the pressure from the nerves and you're stabilizing the segment. You're taking all motion away. After you're done with a successful spinal fusion, there's nothing else to do. The segment is permanently fixed for their lifetime. So that's very attractive. As opposed, let's say you do a partial discectomy or a microdiscectomy. You've just removed that piece of disc, that level can become injured again. It can herniate again. So a spinal fusion, complete treatment. The other thing I really like about spinal fusion, and this becomes kind of interesting with workers' comp patients, is there's a treatment endpoint. So after 4 to 6 months of healing, I can get a CT scan that shows the fusion has healed. There's nothing else to do. If we identified the injury prior to surgery is at the L4-5 level, and I've taken the pressure off of those nerves and I've fused it successfully and I see it on CT scan, there's no further surgery to do. You're at maximal medical improvement, maybe. We can have those discussions. As opposed to if you do a laminectomy alone, that motion can still move. So you haven't treated everything at that level. Are they at MMI? I don't know. Is there something else to do? Do they need a fusion? So that's one of the really nice parts. Now, you just can't talk about advantages. There's also disadvantages. Fusion is a bigger surgery. It takes longer. There's more blood loss. There's higher risk to the patient. You stay in the hospital for 2 days. It's generally a longer recovery time. The other thing is more resources. Time and money. Time and money are more. Patients are always concerned about stiffness. This is probably the number one question I get when I'm talking about spinal fusion. Am I going to be able to bend over? Yes. Yes, you are. My number one, and maybe better. Maybe you'll bend over better. My point for that is your pain's going to be gone. And I also remind them that segment didn't work anyway. That spinal segment that we're fusing, it was unstable. It didn't move anyway. So spinal fusion of one or two spinal segments is not a big stiffness issue, in my opinion. Now, once you start getting to 3 or 4 lumbar segments, it's a little bigger issue. Okay, and then this is the thing I don't like, is adjacent level spine disease. For degenerative spine disease, which is going to be basically people over 50 years old that come in with just wear and tear and age-related disease, if you fuse it, you're not stopping the aging process. You're not stopping genetics. What I tell patients is I can fix what's broken today, and then we have to watch for what happens tomorrow. So the spine that we fuse today is permanently fixed. 10 years down the road, 1 to 2 out of 10 patients are going to need another fusion. That's my estimate. That's what I've seen. Okay. All right, the spine is a skyscraper. All right, sources, this is really just my clinical practice and the x-rays from my practice. I got some images from some different sources as well. So, all right, thank you very much. I think, well, it looks like we probably, about 10 minutes for questions. Okay. Sure.
Well, more of a comment. The lady who was permanently stuck over and you fixed her with like the 8-level fusion, that's actually my mother-in-law, and she is doing great. She walks 5 or 6 miles a day. But next time, can you fuse her mouth?
No, that's a real success story because some patients are just, they're in so much pain and they're on pain medications for so long, and yeah, that's a really great one. Yeah.
For the person that had the metastatic breast cancer, what did you use for the graft material? Would we be able to use bone morphogenic protein?
Yeah, man, that's a whole lecture in itself. There's some people that think bone morphogenic protein increases the risk of cancer, and then there's several studies that say there's no significant association between the two. But in those patients, we use their local bone, so their local bone that I harvest that's not related to tumor. And then there's other bone graft agents that we can use, demineralized bone matrix. Right now I'm just spitting out terms, but BMP is powerful. In some patients, you tend to stay away from it. That's correct. But there's alternatives. Exactly.
She did well with.
Oh yeah, she's doing great. Yeah, that was a satisfying case because it was such a young woman and she couldn't walk. It was the spinal cord ended on her around L2, which is where her fracture was. So she actually had a spinal cord injury, and she was really struggling. I just saw her back. She's doing okay. Her cancer was really out of control. It's all over her body, but she's doing okay.
How much time limit as far as the smokers? Do they have to stop ahead of time?
You're going to get a different answer from every spine surgeon, but my protocol is this. They need to quit for 2 weeks and then call me back and let me know that they quit. And when I say stop smoking, I also mean nicotine, okay? Because that's how I test. You know, there's no cigarette test. It's a nicotine test, a serum nicotine test. And for those metabolites to clear your body, it takes time. It takes several days, a week. So after 2 weeks, if they've quit using nicotine, I'll send a serum blood test, okay? And if that's clean, then they have quit. And at that point, I trust them, okay? And then then I'll start scheduling surgery. I want them to stay tobacco-free for a year. I tell them forever, but at least a year. Yeah, I just want to treat their spine, I guess. Trust me, if tobacco didn't make a difference, I'd operate on smokers all the time.
Can you just talk about, from the workers' comp perspective, on your different fusions, the post-operative protocol, the return to work sequence, and kind of how that goes? And I guess use your general labor class as kind of the model for that.
Okay. I'm still figuring this out. I don't think anyone has a right answer. In fact, we just had a round table with the surgeons at my group. We had a little workers' comp meeting, And everyone has their own little way about this. There's no written rules. But I would say I really try to approach all the patients the same. I do. Workers' comp patients are a little different, and that's just the truth of it. But what I would say, no work for 6 weeks, sedentary, okay? So just right away, no work. You're just walking, that's it. Wear a brace. Then I come back, I get an x-ray, see how they're doing. Then I like to get them back to some sort of duty. So I'll say light duty, lifting 15 to 20 pounds, no excessive bending and twisting to lift loads, have to wear the brace, okay? And there's some companies and some skill sets that's not a possibility, and they continue to be out of work because no one can accommodate that, okay? Then I bring them back at 3 months usually, or 3 to 4 months, and I get another x-ray. And by this time, the fusion, the biological process is starting to heal. Those bones are coming together, and I'll start loosening up the restrictions a little bit. I base some of it on how the patient is doing symptomatically and how their x-rays are looking and how healthy they are. But then I'll loosen it up to 30 to 40 pounds, okay? And we'll start having them work a little more. And then at usually 5 to 6 months, I let them go back to duty, hopefully what they were doing before. There was a discussion about, do patients with a spinal fusion have any sort of permanent work restriction? And I've seen it both ways. There's some of my partners that say there's no permanent work restrictions, and that there's others that say there are. I think I'm leaning towards there is some sort of work restriction for these patients. The spine is not normal, the biomechanics are not normal. So I think that's really a case-by-case basis for patients, but man, lifting more than 75 pounds is going to be tough. Like putting that amount of stress to your spine after this. So yeah, hopefully by 5 months they're getting back to some sort of medium to medium labor heavier job. Each case is different. I don't have hard rules. I like hard rules, but I don't have it for this.
Is your concern the fusion itself, or is it, when you talk about levels above and below, obviously we see that.
Yeah, so
More the above and below, or is it more the fusion itself?
it's the above and below. Because as I said, once those bones have healed together, it's permanent. It's solid. You're not going to break it unless you're not going to break it. I can't even think of a circumstance where you're going to break it. It's happened, but it won't break. So then I'm concerned about the levels above and below. Yeah. Any other questions? Yeah. I'm ignoring this side of the room. I'll get over there if there are any. Go ahead.
I have an injured worker who is in his 70s, and he ended up having a 4-level fusion because of a job injury. And now the levels above and below are deteriorating, and the recommendation is to do a full fusion. So there's like 6 views. I mean, is there a limit at what you stop at, or because it seems like that guy would have no motion?
It's a great question. I had a patient come in who's had several spine fusions, and now he's got adjacent level disease, and that's what you're describing. He needs another fusion. And he goes, haven't I spent all my fusion money? And this is America. If you have functional goals and you have disease and you have insurance coverage through a program, we'll treat the disease. And there's no limit. I'm not proud of that statement. There's no limit. Every spine surgeon that's practiced for any length of time, I'm not quite there yet, but they have a patient that's fused from the very top of the cervical spine all the way down to the pelvis, just one long set of rods. And that happens, and I don't think any spine surgeon is proud of that. That's just the nature of spine disease. Spine disease is incurable. Spine disease it's incurable. You can fix what's broken today, and then you watch for what breaks tomorrow. Man, that's pessimistic. But it's just, I'm just honest with my patients. If something is structurally wrong and it's causing severe pain and dysfunction, then we fix it. It's worth it. But the truth is, we can only fix what's wrong today. You can't stop aging. You can't stop life. You can't stop genetics. These are all factors that contribute to spine disease at other levels that probably contributed to your initial fusion. And then we treat those. Now, there are limits. I mean, and that's where professional judgment comes in. If you have an 85-year-old patient that has congestive heart failure, and congestive heart failure is just an example, or other medical problems, and they're really deconditioned, then I would recommend against it. Yeah. So that's a hard part of the job, is telling patients no. Okay. Any other questions? Yep.
So in a case like she just mentioned, if there is not any additional injury, how would you address causation in a case like that? Because we're looking at that 10 to 20% fusion above and below. How then are we looking at causation?
Yeah. Man, that's a great question. Sometimes there's a part of these narratives that ask, will the patient need any ongoing care, treatment or care? And I've started to put in this little statistic about adjacent level disease, 10 to 20% at 10 years is kind of like what I've seen. There's research papers that have that number all over the place. But I'm a little, fortunately, I haven't had to deal with adjacent level disease personally. I have one case right now that I actually inherited from another surgeon, and it was done about a year or two ago. The patient had the surgery, and then within a year developed adjacent level disease. And that level was normal before her surgery. So I'm calling that, in that case, I'm calling that spine related to the initial spine fusion. I think that's related to the injury. I'm sure everyone has opinions on that. I don't have the right answer. I'm just telling you a little bit about my experience. It's a great question. I don't have the perfect answer for that. I do think adjacent level disease that comes quickly is probably related to the fusion. What's quickly mean? I'm not sure. Okay. Any other questions? I think that's about the time I had, so perfect. All right. Well, thank you everyone for having me. That was fun. Send me, yeah. I'm happy to see any patient you want. I enjoy complex cases and routine cases, and I enjoy second opinions. So thank you very much.